Welcome to the deep dive. This is where I try to, synthesize really complex, sometimes quite confusing, medical material into a roadmap you can actually trust.
And today, our mission is to cut through all that noise surrounding a topic that's, it's incredibly common, it's deeply personal, and frankly, it's often marketed really aggressively.
Vaginal laxity. We're essentially translating the core philosophy and the detailed guidance from the Women's Health Clinic into a guide for you.
And we absolutely have to. I mean, the source material makes it so clear. Vaginal laxity is one of those things that it's a patient-reported sensation that drives so many late-night worried internet searches.
Right, the 2 a.m. Google search.
Exactly. And when you think that up to 40% of women who've had a vaginal delivery experience this to some degree, well, the clinical response just has to be measured. It has to be evidence-aware and, put patient safety first.
And that's the standard of care we're really drilling down into. It's all rooted in the philosophy of the source material's author and reviewer, Dr. Farzana Khan.
Her background is so key to this whole high-trust approach.
It really is. We're talking about, over 2 decades of specialist medical experience across both dermatology and obstetrics and gynecology?
Yes, she qualified with her MD from the University of Copenhagen way back in 2003, then her MRC GP, and the diploma of the Faculty of Sexual and Reproductive Health in 2013. It's a huge breadth of experience.
And that combination, derm and O&G, that's actually quite unusual, isn't it?
It's rare, and it's so critical for this topic. I mean, she looks at complex vaginal health, whether it's GSM, lichen sclerosis, or these feelings of laxity, with a holistic view. She's looking at the surface tissue and the underlying support structures.
And her whole practice is defined by a phrase in the source material I loved: clear explanations, realistic expectations, and shared decision-making.
That's the ethos. That's the blueprint. Prioritize what works, be transparent, and start with conservative care.
Okay, so let's unpack this. The first job, I think, is to get a really clear definition of what laxity even is, and then introduce this crucial idea that drives everything else. The solution has to match the root cause.
Get that first step wrong, and the whole thing falls apart.
Exactly. So when we're talking about vaginal laxity, this feeling of looseness, the first point is that it's subjective, right?
It's the absolute cornerstone. We have to establish that right away. It is a patient-reported sensation. It is not a diagnosis you get from a blood test or a scan.
The patient's feeling is the starting point.
It's the primary data point, and that's why it can be so confusing.
Because a woman might say loose, but what she's actually describing could be, anything. Friction, or maybe pain, or that feeling of air getting trapped.
Or a lack of muscle control, which is why the clinic's framework, this idea of the 3 layers of support, is so essential. It cuts through that ambiguity.
Right, it helps categorize the problem. So let's break them down. Layer 1, that's function.
Layer 1 is the muscle system. It's your pelvic floor. So if that feeling of looseness is driven by a lack of active support, this is where you focus.
And we're not just talking about a quick squeeze, are we?
No, not at all. We're looking beyond just basic activation. We're assessing endurance. So, can you hold a contraction for 6 to 10 seconds? And coordination.
What does coordination mean in this context?
It's about timing. It includes that critical skill that physios call the knack.
The knack.
Yes. It's that tiny preemptive squeeze you do just before you cough or lift something heavy or jump. If that layer is weak or uncoordinated, the feeling is often a lack of control, a sort of give when you're active.
And the beauty of starting here is that pelvic floor muscle training, or PFMT. That's the safest, most evidence-backed first step for pretty much everyone.
It is. It's always the right place to begin.
Okay, so that's layer 1, muscle. What's layer 2?
Layer 2 is surface comfort. This is all about the vaginal mucosa, the lining itself. And this layer is massively influenced by something called Genitourinary Syndrome of Menopause, or GSM.
This is what the source is called the loose yet sore paradox. I found this fascinating. How can feeling dry or sore make you feel loose? It seems completely counterintuitive.
It does, but it's critical to understand. When estrogen levels drop, the tissues get thinner, more fragile, and they lose their natural elasticity.
So they don't glide as well.
Exactly. You get more friction during movement or intimacy. And that leads to dryness, stinging, and these horrible little paper-cut micro tears.
And I imagine if something is constantly sore, your body just sort of guards the area.
It does. It tenses up. So a woman might describe that as feeling loose because there's this awkward friction or it's just too tender. But the root cause isn't a lack of muscle support. It's poor tissue quality.
So if friction is the main problem, the solution isn't trying to tighten things. It's about managing that friction.
That's it. It's friction control and local tissue therapy. And if you use a tool for a different layer on a layer 2 problem, you won't get results. You might even make it worse.
Which brings us to layer 3, structure. This is the anatomy, the actual geography of the area.
Yes, layer 3 is about the physical geometry or the integrity of the fascia, the connective tissue.
So what are we looking for here? What kind of issues fall into this category?
We're looking for obvious anatomical things. A perineal scar from childbirth that's badly positioned or tethered. A deficiency in the perineal body. That's the muscle between the vagina and anus. Or a discrete fascial defect, like a rectocele or a cystocele.
A prolapse, basically.
Yes, or any pelvic organ prolapse that's actually descended beyond the entrance to the vagina. These are problems with the literal physical structure.
And that explains the clinic's warning. You can't use a superficial tool, like an injectable, for a layer 3 structural problem.
It's like putting a Band-Aid on a broken wall. You're setting the patient up for disappointment. They spend time and money, and their actual symptoms, the air trapping, the heaviness, they don't improve because the underlying structural problem was never addressed.
Assessment first.
Always.
Always. Okay, let's walk through that assessment. So say I come into the clinic and I'm describing this vague feeling of looseness. What does a proper structured assessment actually involve?
Well, it has to be comprehensive. It always starts with a detailed history.
So asking questions.
Lots of questions about your births. Were there instruments? How severe were any tears? Your menopausal status? Do you have any other issues like leaking or urgency or a feeling of heaviness?
And then practical functional questions.
Crucially, do you notice air trapping when you do yoga or exercise? Has your sexual sensation changed? And a really important one, how well do you hold on to a tampon or a menstrual cup when you're active?
That tampon test seems like such a simple but really powerful indicator.
It is, because it's a real-world test of both layer 1, the muscle function, and layer 3, the structural geometry. If the muscle can lift and the entrance is stable, the tampon stays put. If there's a significant gap, it tends to slip out.
Now, beyond the subjective history, the source material does say there are objective measures.
Yes, absolutely. For layer 1, muscle function, we can use tools like perionometers or vaginal manometry to actually quantify the strength and tone.
And for layer 3, prolapse.
We use a system called the POBQ, which is the Pelvic Organ Prolapse Quantification System. It's a way of staging how far things have descended. So these are vital for tracking physical change.
But the overall diagnosis of that feeling of laxity, that's still based on what the patient reports.
It is. We often use validated tools like the Vaginal Laxity Questionnaire, the VLQ.
Right, that's the one with the simple 1 to 7 scale, where 1 is very loose and 7 is very tight.
Exactly. It just gives us a way to make that confusing personal feeling something we can actually track over time.
So if a patient goes through, say, 12 weeks of physio and their VLQ score goes from a 3 to a 5, that's a real measurable success.
That is a clinically relevant success. The focus is always on function.
So the message seems incredibly clear. Before you even think about anything else, you have to optimize layers 1 and 2. That's the foundation.
That's the non-negotiable first step. It's built on the highest quality evidence, and it's consistent across all the major UK guidelines.
Like NICE guidance.
Yes. NICE guidance, NG 123 for prolapse, NG 23 for menopause. They consistently recommend supervised PFMT and GSM care as the first line approach. It's where you have to start.
Okay, let's dive deep into that. Pelvic floor muscle training. I think a lot of women hear that and think, oh, I do my Kegels. But the evidence insists on something much more specific.
It does. It requires commitment and structure. A high-quality block of training means at least 12 weeks of progressive work. It's about consistency, not just a few squeezes here and there.
And it's not just about raw strengths, is it?
That's a huge misconception. The real goal is coordination and endurance. You're training the slow twitch muscle fibers to sustain that hold.
That 6 to 10 second hold you mentioned earlier?
Exactly. That's the endurance that supports you through a whole day of being on your feet or lifting things.
And what about the coordination piece? Is that just about doing it right?
It is. So many women make common mistakes. They hold their breath, or they bear down instead of lifting up,
Right.
or they tense their bum and their thighs instead of isolating the pelvic floor.
So supervision is key to getting that right.
Absolutely. Supervision ensures you're using the correct technique, and it's how you tailor the progressive training over those 12 weeks. And critically, it's about teaching the knack, that split-second lift before the pressure hits.
It's amazing how many women try to do this on their own and get it wrong. The sources said up to 50%.
That's right. And if you're bearing down, you're actually making things worse. You're increasing the pressure. That's why seeing a specialist pelvic health physio is so important.
So that should be the first port of call before even considering any procedures.
For anything.
Yeah.
The physio clarifies the diagnosis. Is it simple weakness that needs strengthening? Or is it an overactive, painful pelvic floor that actually needs down training and relaxation first? You have to know what you're treating.
Okay, what about all the gadgets and devices marketed for this? Biofeedback, e-stim, those cones, where do they fit in?
They are learning aids. They are not the solution in themselves.
So a bit like a mirror at the gym.
That's a great analogy. Biofeedback is a mirror. It gives you visual or audio feedback to confirm that you're squeezing the right muscle. Electrical stimulation, or e-stim, is really just for cases where someone literally cannot feel or activate the muscle. It sort of wakes up the nerve pathway.
But they don't replace the actual work.
They never replace the active progressive training.
Okay, let's move to layer 2, surface comfort and GSM. This seems to be the step that gets missed so often.
It really is, especially for women who are peri or postmenopausal or even breastfeeding. The drop in estrogen thins the tissues, makes them dry, and that amplifies friction.
Creating that loose yet sore feeling.
Exactly.
So let's talk specifics on management. The sources make a big distinction between a moisturizer and a lubricant.
A vital distinction. A vaginal moisturizer is for routine hydration. You use it on a schedule, maybe 2 to 4 nights a week, regardless of sexual activity. It helps the tissues hold on to water.
And a lubricant is?
A lubricant is for on-demand use, for specific high-friction moments. And you have to make sure it's compatible. Water-based is versatile. Silicone-based gives a longer glide.
And if that's not enough?
Then you escalate to the most targeted, evidence-based option for GSM, which is low-dose local vaginal estrogen.
And how does that work?
It works by directly rematuring the vaginal lining over a period of about 2 to 6 weeks. It makes the tissue thicker, more robust. It fundamentally improves tissue health.
But, and this is a really important point, it doesn't tighten anything structurally, does it?
No. It improves glide and comfort, which makes women feel better supported, but it does not mechanically tighten fascia. We are optimizing the environment, not changing the architecture.
Which is such a key philosophy. Finally, on the foundation's lifestyle strategies, managing the load on the pelvic floor.
Yes, you have to manage the external pressures.
What are the big ones?
Number 1, chronic cough. From smoking, asthma, whatever, it's incredibly damaging. Number 2, constipation. All that straining is immense downward pressure.
So fluids, fiber, and using a footstool.
Absolutely. Getting the posture right is key. And number 3 is breath control when you're lifting. Always exhale on the effort.
And simple things like vulval skincare.
Simple is best. Fragrance-free products, lukewarm water, breathable cotton underwear. All these things reduce chronic irritation, which is a huge part of that layer 2 discomfort.
Okay, so this is where the conversation gets really interesting and where we have to be the most critical. The foundations are solid, PFMT is optimized, friction is under control, but what if there's still a residual symptom, a mild entry-focused gap?
This is when we can cautiously start to talk about adjuncts.
And we have to stress that word, adjunct.
We have to, because neither energy devices, so laser or radiofrequency, nor injectables can replace that foundational work. They don't fix a prolapse, they don't correct a fascial defect. They are positioned as tools that might nudge superficial tissue quality.
Let's talk about the governance around energy devices first, because this is huge. What's the official stance in the UK?
The context here demands extreme caution. The UK's NICE guidance classifies transvaginal laser for this purpose as investigational.
Investigational, which means research only.
It means it should be used in a research setting, not as standard routine care. And internationally, the warnings are even stronger.
The FDA in the US?
Yes, the FDA issued significant safety warnings. They cited reports of serious complications, burns, scarring, chronic pain, nerve damage. These are not trivial risks.
And then Australia's regulator, the TGA, they went even further. They're actually canceling approvals in 2025.
They are, and that's a massive statement. When a national regulator cancels approvals, it means the evidence for long-term safety and performance just isn't there. The risks outweigh the proven benefits.
So for any clinic in the UK offering these devices, they have to have very special arrangements in place.
Strict governance, very detailed consent, ongoing audits. They have to acknowledge the investigational nature of what they're doing.
Which brings up a question for me. Given all this, the strong evidence for physio, the global warnings about devices, why do women still go for these expensive, risky procedures?
I think it comes down to marketing and the desire for a quick fix.
An instant solution.
Exactly. The marketing promises tightening without the work. Supervised physio takes 12 weeks of consistent effort. A procedure feels instant. And the role of a high-trust clinic is to guide the patient back to the evidence, to explain that a temporary fix will always lose out to robust foundational health.
Okay, let's shift to regenerative injectables. PRP, polynucleotides, HA boosters, these are positioned a bit differently, aren't they?
They are. They're positioned as superficial comfort layer solutions for those mild entry-focused symptoms like micro tears or a specific point of stinging.
Let's break them down. PRP, platelet-rich plasma, what's the story there?
So PRP is autologous. It comes from your own blood. We take a blood sample, spin it in a centrifuge to concentrate the platelets and growth factors, and then inject that solution superficially. The aim is to stimulate a local healing response.
The big advantage is the low allergy risk, because it's your own stuff.
That's the pro. The con, and it's a big one, is variability. The quality of the PRP depends entirely on your own blood at that moment in time and the clinic's processing protocol. So results can be very individual.
Right, so if PRP is natural but variable, what about polynucleotides?
Polynucleotides are different. They're purified DNA fragments, usually from fish, formulated into a gel. They work through biostimulation, they support tissue remodeling and attract water.
And the advantage there is consistency.
Exactly. They are batch standardized. So the clinician knows exactly what concentration and what quality of product they're delivering every time. The obvious caution, though,
is the fish source.
Right. You have to screen very carefully for any fish sensitivity. The risk is very rare, but it's not zero.
And lastly, HA skin boosters. Hyaluronic acid, but you were very clear these are not fillers.
A critical distinction.
Yeah.
Deep volumizing fillers are not appropriate here. These are low viscosity, superficial skin boosters. Their job is to draw water into the surface layers of the tissue.
So they hydrate and cushion.
They hydrate, they cushion, they support glide, they reduce friction. They are a layer 2 comfort tool, not a layer 3 structural fix.
And if someone is a candidate for these, what's the protocol? Is it a one and done?
No, it's usually a short series, maybe 2 or 3 sessions, spaced 4 to 8 weeks apart. Then you review a couple of months after the last one, and maintenance. That really depends on the person and how well they stick to their foundational care.
That makes sense. And what about combining these treatments?
It's only done in very carefully selected cases, and the sequencing has to be incredibly strict.
Why so strict?
Attribution. You have to know what works. So you add one thing at a time, you space the sessions out, you put injectables between device sessions, not on the same day. Yeah. It's about being methodical so you can clearly see what's providing the benefit.
Finally on this, safety. What are the non-negotiable red flags that mean you have to stop and defer any procedure?
This is so important. Any active infection thrush, BV, a UTI, has to be fully treated first. Fever, foul discharge, or recent surgery without clearance are absolute stops. But the biggest one, the one that requires immediate separate investigation, is new postmenopausal bleeding. Yes. That symptom must be investigated to rule out serious pathology before you do anything else.
And we have to be clear, if the problem is clearly a big prolapse or an overactive pelvic floor, these adjuncts are not the answer.
Completely unsuitable. If those issues are present, the pathway has to shift immediately to a proper structural assessment.
So we've come to that point. We've maximized the muscle function, we've optimized the surface comfort, but key symptoms are still there. This is when we have to seriously focus on layer 3 structure.
This is the shift.
What are the telltale signs that the problem is truly structural?
We're looking for symptoms that just don't get better with strengthening or hydration. Very physical things. A visible or feelable bulge when you strain.
The need to splint, as the sources call it.
Yes, needing to use a finger to support the area to empty your bowels. That's a classic sign. Or your tampon or cup constantly slipping out, even after months of good physio. Obvious hair trapping. Or a perineal scar that's clearly tethered and distorting the anatomy.
If those signs are there, what is the mandatory next step? And why does it have to come before any thought of a device or injectable?
The mandatory next step is a targeted assessment by a urogynecology specialist. It has to come first, because those surface treatments will not fix a fascial defect. They won't move a scar.
It would be unethical, really.
It would be unethical and futile. You need clarity on the underlying architecture first.
Which brings us to the very end of this decision tree, surgery. Specifically, perineal scar revision, or a repair.
And this is reserved for confirmed structural issues that persist after all that optimized conservative care has been done and maintained.
And the goal here is absolutely not cosmetic tightening.
No. The goal is functional improvement. It's about restoring the integrity of the structure.
So what are the realistic functional benefits a patient can expect from a well-indicated repair?
The benefits are tangible. A steadier entrance contour, which can reduce that air trapping. Fewer of those little splits at the back of the entrance because the geometry is better. And really importantly, can improve tampon and cup stability.
So it's about comfort and being able to return to activity without problems.
It's about functional support. That's the goal.
And what does recovery look like? Do you just have the surgery and you're done?
Not at all. Recovery is significant. You're looking at a 4 to 6 week pause at least from high friction activities. And then critically, you have to resume your pelvic floor rehabilitation.
To protect the repair.
Exactly. The surgery provides the new structure, but the muscle function layer 1 has to be maintained to protect that structure from strain in the long term.
Okay, let's bring this all together. Outcomes. In this high-trust model, success isn't about marketing claims, it's about practical, patient-reported metrics.
Always. We judge success by tracking what the patient actually reported as their problem. Over 6 to 12 weeks, we track specific things. Sting scores, how many days they had micro tears, ease of penetration, how often air trapping happens.
Tampon stability.
Tampon stability. If those functional things improve, the pathway was a success. We're not chasing an arbitrary number on a tightness scale. We're chasing quality of life.
And what are the universal factors that predict the best long-term results, no matter which treatment path a woman went down?
It always comes back to the foundations.
Yeah.
Always. It's the continuous supervised PFMT. It's the scheduled use of moisturizers and lubricants. It's sticking with local estrogen if you need it.
And managing those load factors.
Aggressively managing chronic cough, constipation, all of it. Aging and hormonal changes are going to happen, but that consistent foundational care is what preserves the improvements you've made.
It's a stepwise, evidence-based approach that really seems to honor Dr. Khan's ethos. The safest, most effective things first.
It's about respecting the evidence and the patient's concern. The sensation of laxity is complex, and the treatment has to be personalized and stepwise. It has to prioritize functional comfort over marketing claims.
So addressing you directly, remember those 3 layers: function, surface comfort, and structure. If you feel loose or sore or both, the path is clear. Starting with a 12-week block of supervised physio and optimizing that friction control is the evidence-backed first step.
And here is a final provocative thought for you to consider, which ties back to all that caution we talked about earlier. Given the really robust international concerns about intimate energy devices, the FDA warnings, the TGA cancellations in Australia, what are the essential questions you should ask your clinician before considering any procedure outside of that guideline-recommended conservative care? Hint. Ask them specifically for the long-term peer-reviewed data that supports its use beyond 12 months. Ask them about their clinic's internal governance and their audit procedures for complications. And ask them what evidence confirms that this expensive procedure is actually superior to 12 weeks of supervised physio and local estrogen.